Hello and welcome everybody to ICMDA webinars. I'm Dr. Peter Saunders, the Chief Executive of the International Christian Medical and Dental Association, which brings together about 60,000 Christian doctors and dentists from over 100 affiliated national movements worldwide. And today on ICMDA webinars, we have Professor Bertha Rathinam, who will be speaking to us on the issue of reimagining cancer care, holistic prehabilitation. So, reimagining cancer care, holistic prehabilitation. Cancer prehabilitation prepares cancer survivors, including caregivers, for the rigors of cancer treatment in whatever time they have before it starts. It employs a multidisciplinary approach, primarily targeting the physical, nutritional, and psychosocial needs of the survivors. It provides specific interventions and monitoring after screening and assessment to all cancer survivors. And it has proven beneficial in enhancing recovery after surgery and improving tolerance to complications. And our speaker today is Professor Bertha Rathinam. Professor Bertha teaches anatomy at the All India Institute of Medical Sciences in Bhopal, India. She's interested in cancer survivorship care and is passionate about raising awareness on cancer prehabilitation and rehabilitation as support care to the standard clinical management of cancer survivors. She is also, in her spare time, the ICMDA Regional Secretary for South Asia. So, Prof. Bertha, it's a real pleasure to have you here today, and we look forward to hearing you speak. We're not seeing you at the moment, so if you just turn on your video. Brilliant. There you are. Thank you very much. So over to you, and we look forward to hearing what you have to say and then engaging with you in the Q&A afterwards. Thank you very much.
Thank you so much, Dr. Peter. Good evening, good afternoon from wherever you are. Thank you so much for joining today. And I'm really delighted to talk about a very transformative approach in cancer care continuum, holistic rehabilitation. Oncologists are often concerned about survival, and all their efforts are focused only on disease-free survival or remission. Sadly, the quality of life and management of late effects of treatment are not given any consideration. Our aim as healers is not only to ensure that every person who is diagnosed with cancer survives, but also lives life to the fullest, functionally, physically, emotionally, and mentally from the very onset of the journey. Who is a cancer survivor? Let's begin by redefining the cancer survivor. We often think that survivorship starts after the treatment or at remission. But modern oncology says it begins at diagnosis, from the day of diagnosis. In fact, one of the literature that I read says at the suspicion of diagnosis and continues through the person's life. And whether the cancer is treatable or not, they are cancer survivors. It includes the families, friends, and even the voluntary caregivers of those affected. This inclusive definition helps us to reorient our care, not just treating cancer, but also supporting the whole person and their family and the caregivers and the community. With increasing incidence of global cancer, about 24.6 million new cases are expected by 2030. We also know that there's going to be an increasing survivorship. So what is cancer prehabilitation? It is a proactive, patient-centered model of care that introduces elements of rehabilitation, if we can say so, even before the active cancer treatment starts. It can be before the start of your surgery or neoadjuvant chemotherapy or even radiation, with the objective of optimizing functional outcomes. physical fitness and improving their psychological well-being, nutritional status, so that the patient is adequately prepared for the rigors that they have to face, and also improving tolerance to the toxic cancer treatment. Is it something that is needed? Firstly, because patients value taking control of their own health early on in their cancer journey. There is scientific evidence to show that when they are prepared physically and psychologically, they have better outcomes, fewer complications, better recovery, and all these lead to greater quality of life. And thirdly, multimodal prehabilitation approach for the people is more effective and superior, far more superior to focusing on a single aspect of just physical fitness or nutrition or psychological support. So as we can see from various researches, cancer prehabilitation shows improved cardiovascular fitness and nutritional status. The buzzword eras, enhanced recovery after surgery, reduces the length of hospital stay, and it even can fit you or make it possible for you to receive a newer treatment which you were otherwise not eligible for because of your physical condition. And the diagnosis is a teachable moment. It's a grave disease. It's still, and that period when you are still amenable to learning can bring about potential long-term behavioral changes, stopping smoking, alcoholism, or improving your physical fitness by increasing your daily activity, and have a positive health impact on the long run. And everything, each of these adds up to better quality of life in the cancer survivor. It may not be needed for everyone, but there are some who might need it desperately, and we should not miss those who have these unmet needs. And assessing needs, the screening tools that we use have to be standardized or validated, and it should be allied to the holistic needs assessment. And assessments can include subjective patient-reported outcome measures, a few examples of what I have shown on the screen here today, or it can be objective tests, physical fitness tests like the 6-minute walk or the timed up and go test, the 30-second chair stand test, or assessing the nutritional status. Most of us are familiar with the malnutritional universal screening tool or the mini nutritional assessment, whatever is feasible or possible for your area or your hospital, whichever is being followed can be used. And mental health also needs to be assessed using patient health questionnaire. Many of us are familiar with generalized anxiety disorder assessment or hospital anxiety depression scale. There are also specific cancer-specific tools which are done by the European Organization of Research in Treatment of Cancer. And they have specific tools for quality of life, physical function, nutrition. You can use any of those scales that are available and assess the needs of any deficiency. And most of them will need a specific intervention. So once we know that there is an unmet need in cancer survivors, then we need to address it. So we have a common set of interventions that is applicable to anyone with cancer and any type of cancer and their families. So this mainly is grounded on the 3 pillars of rehabilitation: the nutritional, the physical or the functional, and the psychological support. So we assess the deficiencies and we give tailor-made exercises and nutritional increased protein and psychological support. Some might just benefit with counseling, some might need cognitive behavioral therapy, some might even need pharmacological intervention by some antidepressants and drugs. And also, it's important for us to signpost those to specialist care. So the interventions are usually done at 3 levels. Universal, as I mentioned, which is suitable for all with cancer and any type of cancer. And that's basically on the 3 principles of physical, nutritional, and psychological pillars. So we assess them and address those things. Or it can be targeted. Many of our cancer survivors might have comorbidities like long-term diseases, diabetes, hypertension, and so they will need some targeted interventions during the treatment in control of the other diseases. And also some survivors who have a higher risk of developing late effects of the disease. Or like, for example, in people with head and neck cancers or oral cancers, it's advantageous to start with speech and swallowing therapy or prehabilitation exercises even before they lose the organ. And some who have complex needs, like those with severe impairment, disabilities, and long-standing other illnesses, might need more intense specialist care. So it's very important that we address these needs with the specialist care under supervision. These are not to be done without any supervision. So universal, it's something that anybody can do at home. It's a home-based care, and it can be followed up virtually from wherever they are. And some of the common problems that they have can be self-managed. But targeted and specialist interventions need supervision, and it has to be individualized and tiered for the respective candidates. But in all cases, empowering self-management and connecting people to the right resources is the key in cancer rehabilitation. Scientific evidence is clear, as literature shows that combining physical, nutritional, and psychological interventions yield better results than working in isolation. And implementing rehabilitation is not just a static process, it needs regular monitoring and ongoing quality improvement. So we track patient outcomes by measures of fitness scores, complication rates, well-being, and we refine our interventions as and when these new symptoms arise, so that we make sure that every individual gets an optimal and an individualized care. So this picture here shows of a research which has been done in the UK, and how rehabilitation has helped in improving the overall fitness and recovery of the individuals. So this was in major gastrointestinal malignancies. The starting point is the same. And for those who had prehabilitation, and it is understood that even rehabilitation for 2 weeks, like 10 days of exercise or prehabilitative intervention, can bring about a good increase in their physical fitness and overall strength, and also improve their improved resilience to metabolic stress of surgery or chemotherapy. And also it helps in reducing the post-operative complications and better outcomes at the end. And you can see from these graphs that someone who has not had a prehabilitation declines very fast, and they are not able to even reach up to the starting point that they started with, because of the rigors of the treatment and the stress of metabolism and everything added together. But you can see that when there is prehabilitation, there is a good improvement, and they can even attain a level of functional fitness better than their starting point. So this is something that is very important for all cancer survivors. How do we go on addressing this issue? If we already have it in our systems, it's good. But in case it's not there, we need to have a reliable patient-centered care, identifying and prioritizing the areas that matter most. So part of it could be pain relief, nutrition, uh, preparing them physically, mental health, infection prevention. And also sometimes we fail to give importance to the alternative therapies that might be existent in their culture, or complementary therapies. We often fail to include them in our standard care. And we can use processes like Delphi technique with expert and patient input to create culturally sensitive guidelines, especially relevant for the resource poor setting. It's not advisable to say everybody go to a gym and do high intensity interval exercises. That's not what we are looking at. But recommendations which are actionable, which are relevant to our culture and context, is very, very important in designing prehabilitation for our patients. Listen to the patients. Patient advocacy is very central to the success of implementing rehabilitation. Through surveys, open communication with the survivors and their family members, understand what their needs are, what are their preferences, what are the key barriers to care, and then work on this and tailor the prehabilitation according to the needs of the survivors in a very supportive and a meaningful way, which can then be effective. So I would like to point us once again to the paradigm shifts in cancer survivorship care these days. The approach to survivorship has evolved. We do not wait until the patient completes treatment and develops serious complications that we cannot address them later. Prehabilitation can prevent or ease some complications. It's proven that exercises can reduce fatigue, can reduce pain in many individuals, and can even prevent sarcopenia to a large extent. And today's survivorship and prehabilitation starts at diagnosis and extends through every stage. So we can have prehabilitation before the start of acute treatment, perihabilitation during their active treatment of surgery or chemotherapy or radiation, and rehabilitation after the treatment is complete. It's a whole continuum. This supportive care is a continuous care, and it needs to start from day one so that it gives better outcomes. And we have learned about universal, targeted, and specialized rehabilitation needs. And also the three pillars I want to reinforce again: the physical, nutritional, and psychological assessments and support, and targeted and specialized rehabilitation when it is indicated for patients with comorbidities and with special needs and disabilities. So this journey is continuous. So let's reimagine cancer care as a journey that supports the whole person from diagnosis onwards, empowering the survivors, engaging the families and their voluntary caregivers, and at least addressing their functional, nutritional, and emotional well-being. Holistic rehabilitation is not just a medical intervention, it's a compassionate, evidence-based approach that can dramatically improve the quality of life and outcomes for those affected by cancer. Let us strive together to put this vision into practice. I would like to thank all the collaborators, the survivors and their families, the organizations whose guidelines and research continuously inform our work and help us to improve care for the cancer survivors. These are my references. I have some additional material to read, and thank you. Over to you, Dr. Peter.
Thank you, Dr. Bertha, very much indeed. So we've been listening to Prof Bertha Rathinam speaking about reimagining cancer care, holistic prehabilitation. And I was saying to her just before that prehabilitation was a term that I wasn't familiar with, but feel certainly much more enlightened now. Now we've got some time for question and answer, and you can put your questions to Prof Bertha through the Q&A icon at the bottom of your screen. Just click on that, type your questions in, and we'll pick those up in discussion. And just a reminder also that we've got translation today into 3 languages, that's Spanish, French, and Russian, and you can access that through the interpretation icon, the little globe at the bottom of your screen. So just to start off, you've talked about the importance of physical care, nutritional care, and psychological care and assessment. Would you like to comment a little bit about spiritual care and what place that has? Because I know many cancer patients, whether they're going to survive or not, are contemplating the end of life. There may be questions about meaning and purpose and what happens after death and so on. So could you comment a little bit on the place of spiritual care in cancer rehabilitation?
Yeah, so as I was mentioning about the holistic needs assessment, actually that tool itself has place for social needs, spiritual needs, emotional needs, and even needs of health information. So when we use any of those standardized tools, we have an assessment of the unmet need of spirituality in individuals. And it's an area that it's very, very difficult to address because different people have different kinds of faith and belief system and spirituality. But one thing I have found in my interactions with patients or survivors is to share the true meaning of spirituality, raise questions which will make them think towards those lines as to and guide them to some spiritual principles that you have found in yourself and help them explore spirituality more. But it's a definite need, and having gone through it myself, I also had those questions, and I found support and answers to most of my questions in the Word of God.
Yeah.
So that is an experience I share with others and ask them to read whatever scriptures they believe in and seek, and then they get the answers.
Thank you. Professor Scott Murray, who works in palliative medicine in Scotland, saying prehabilitation sounds great, holistic care from diagnosis of cancer, without the stigma of calling it palliative care. In Scotland, this support is sometimes called early palliative care. And he's asking the question, which I think you've already answered, can it include spiritual support as we consider in palliative care? So just another response to that. Now, you mentioned during the talk about complementary therapies and the role of those. And I guess that will depend pretty much upon the worldview context that you're working in and the national context you're working in. But can you tell us, what does this look like, perhaps specifically from an Indian perspective? What does it look like to involve complementary therapies in cancer prehab?
Especially the Indian context, we have a lot of, yoga, Reiki, meditation, and so many other non-medical or non-pharmacological interventions, which bring out about the same, results. Sometimes when you are taking such toxic drugs, to have more medications to address the symptoms, with the drug interactions makes it worse. But when you have some complementary therapies, local remedies, like the Indians have a system of ginger water for chemotherapy-induced nausea, which gives the same benefit as would ondansetron. So if we have some complementary or alternate medicines, I think we should be open to promote it and uh, help it, especially because they do not have serious side effects as would the medications do. So if they're not open about exercises, you can tell them about yoga, uh, Reiki, and other things, or some meditations which helps in pain management and improving their concentration, improving their memory. Cognitive impairment is something that is very common with chemotherapy. So these kind of mental exercises help with preventing cognitive impairment. So these are some complementary things that can be addressed and should be encouraged during the supportive care.
Now, Prof, you did some postgraduate study on this in Ireland, doing a master's. Could you just tell us a little bit about what you did during your master's and how it prepared you for what you're doing now?
Yes, I did a master's in cancer survivorship, which is run by the Trinity College Dublin. So our modules basically focused on what are the unmet needs of cancer survivors and how to address them, how to assess them, and how to provide interventions for those needs that they have, and also about how to conduct research in cancer and what are the supportive therapies, what are the national programs which are already existing, and how well you can function along with that, how you can implement something new in cancer care other than the standard antineoplastic therapies that is in practice. So these were some of the modules that were taught to us during my course in cancer survivorship. And that has helped me to come back to India, and I have now started a cancer survivorship clinic and a cancer prehabilitation clinic, where when patients are waiting for the treatment, we assist them and we have some group sessions for their mental health improvement. We, especially for pediatric patients, we have started some structured cognitive exercises for preventing cognitive impairment. We start speech and swallowing therapies even before they go in for the surgery. So these are some things that we have started. It's still recent. We haven't got much data to comment upon it, but we have started working on it. And the very idea that someone is willing to listen to them, address their queries in the waiting period has meant a lot for our cancer survivors. And the fact that somebody is available to be with them through their care, other than the doctors, who are just with yes and no questions for their treatment plan.
Is cancer prehabilitation a relatively new phenomenon? And related to that, can you comment a bit about how widely it's practiced around the world in different regions and countries and contexts?
In the Indian context, it's a kind of new. When I first came back, and I have given a couple of lectures, so when the title went to all our colleagues, my own colleagues, I work in an institute of national importance with 700 odd practicing clinicians, and and with 1,000 beds. So with all the cancer specialties, oncosurgery, medical oncologist, and radiation available in a. So when I sent the flyer out, many of those people replied back to me saying, "Have you misspelled the word?" So that was the awareness even amongst the practicing oncologists. So it's still a new concept, and often we think that only the surgery and chemotherapy and that is the solution for all our cancer treatment, and anything you have to overload, any complication, any symptom, just give them more medication. And nobody looks at the individual as a holistic entity. It's just a patient, the staging is what is looked at, and survival is what is talked about. Nobody addresses quality of life, improved functions during the treatment, I'm a cancer survivor myself. I had cancer 5 years ago. And my own experiences of how I could have had a better time during my rigorous 8 months of cancer treatment made me to think, find out about it. And then I accidentally uh, saw the scores and I went and I've been reading more about it. And now I'm able to, I'm licensed to talk about prehabilitation and rehabilitation and take this clinic forward. I think it's quite well done in UK and Ireland and also in the US. I think from at least for the last 15, 20 years, they have been doing some work on prehabilitation. It's not a new terminology in some of the developed countries.
And thank you for sharing about your own experience. And I was going to ask you, in terms of how your own experience influenced your interest in this, was it because you felt that through your own experience you didn't experience good prehabilitation that has prompted you to really become passionate about this, or was it more that you did experience things that you want to make much more widely available, or was it a mixture of both?
I think, when I went through the disease, nobody talked about prehabilitation to me. And, I, you know, I was advised exercises after I developed lymphedema, while it could have started much earlier and I could have prevented the radiation-induced lymphedema even before it came. So that was kind of not a known concept at that point in time. But I think 5 years down the lane, people are rising up to it. People are reading literature about it. There are some hospitals which the only exercise advice I got was to have a spirometry and blow the 3 balls. That was the only exercise that was advised to me before the surgery. But basically, I am quite athletic. I used to regularly walk, do all kinds of activities. So I already had a level of physical fitness, which helped me through the surgery. But when I saw, and after my own experiences, I started counseling one on one many of my friends who were going through the disease. And then I realized that they didn't have the necessary information that was scientific and that is available. If you just Google has thousands of videos and literature and advices uh, which are not scientifically based or evidence based, and stupid things like drink a glass of turmeric water and everything is taken care of, that kind of thing. So but that's not drink this, but take the pulp of this fruit and have, that's not is what is helpful. So I wanted this proper information on what is right and what can be done to go out to our patients. And that's when I started reading more about it and learned about it. Now I am at least raising awareness about this. I've been talking about prehabilitation in forums that I have been given an opportunity to, and more people are reading about it and more people are wanting to bring it in their systems, in their hospitals.
Yeah. Thank you for sharing that. Scott Murray is saying, again, with regard to palliative care, palliative medicine, we know that the initial focus was on cancer, but now palliative medicine is appropriate to all sorts of chronic diseases as well. And he's asking, is prehabilitation relevant to other life-threatening illnesses like heart failure, or is it just reserved for cancer, or is it just that this is cancer's as far as we've got really so far in its implementation?
The concept of prehabilitation started with major abdominal surgeries. So that's when this started, and it then started for prehabilitation, for cardiac prehabilitation, for people waiting for cardiac surgeries, and also for chronic kidney disease. And I think cancer is the latest entrant into the prehabilitation sequences. So all chronic illnesses are having some amount of prehabilitation. Not many people are aware of it. Not many people are doing it. we normally are famous for doing rehabilitation. So cardiac rehabilitation, kidney rehabilitation, all these are happening now. But I think it's time for us to address it as prehabilitation and take it forward.
Hmm. Thank you. So Elizabeth Searle is asking, how can you help family members to participate in prehabilitation? So she makes the comment, Indian culture often difficult to accept the cancer diagnosis, but families are often receptive to being listened to and want to do something practical. Can you just, you've mentioned involvement of families already, but can you just enlarge on that, how you get people involved and what difference they can make?
So in our setup, what we are doing now is whatever exercises we are telling them, whatever diet we are giving, like a protein-rich diet recommendation and all those, we are asking the entire family to travel along with the cancer survivor. So whatever recommendation that we are doing, including for the exercises, playing mental games or playing games to increase their physical activity, is being done as a family. So to make them involved and be part of the process. And also when the survivor is very tired and physically not able to do, the support from the family kind of pulls them through. Not every family is receptive to that. Some people, in some families, there are members who have to work so that they can take care of it. But the children often are quite open to, especially in breast cancer, children of breast cancer survivors are helpful in engaging the mother and getting being involved in their care, and also taking part in some of the minor needs, pushing them to do things. These are some things that is being done in our setup. And also the dietary part, like that's something as a whole family they get involved in it, and they are doing it. But it's still very early phase. We don't have much to comment on it at the moment, but maybe in due time we will have more data to share how the families are getting more involved in it and more engaged in it.
Mm.
But definitely making them aware of the things that the survivor has to do and how they can help push it is important in involving the family. And also, we have been, when there is a single caregiver, we have emphasized the importance of having other people, other relatives, relieving them and, making the life a little bit easier for the caregivers and the others.
Now, prehabilitation, as you've described it, is clearly a multidisciplinary exercise, both in the assessments, whether it's physical, nutritional, or psychological, but also in the many treatments and interventions that can be brought to bear as well. And I just wondered, who do you think is primarily responsible for ensuring that prehabilitation takes place?
So in our setup, the way we have established our clinic, we have two separate clinics for pediatrics and the adults. So in the adult section, we have a physiotherapist, we have a nutritionist, a dietitian from the hospital, we have a social worker, and we have I'm there. So we do all the assessments, and we have a clinical psychologist. So we do all the assessments, and wherever we have needs, so we put them in with the respective things. And when there is a person with special needs, we call the speech and language therapist, or we send them to the speech and language therapy room for further things. Or even when they need more specific exercises, they are sent to the physiotherapy department. So we have a good team of the technical part, or the multidisciplinary team of physiotherapist, occupational therapist, and a social worker, and a dietitian, and a psychologist. And we have a doctor who's supervising everything. In the pediatric clinic, we have a pediatric neurologist, pediatric cardiologist, and the pediatric oncologist team. We do the with the whole assessment, and then it's the team who takes responsibility and treats them. We are a little bit more mindful of pediatric team, and we are giving them some exclusive care for the moment.
Yeah, so if it's a doctor who's coordinating the whole multidisciplinary process, what sort of qualifications or background does that doctor need? Would it be just a generalist who understands the principles, or does one require special training or specialist development to do it?
I think for the supportive care, someone with a passion for it who can learn the basics of assessments and the interventions is enough. Any general practitioner, even I think even an MBBS person can easily do this. You don't need any specialized care. We are not treating any of the complications of the disease. I think we need to understand that, and we are not interfering with the mainstay of treatment. This is only the supportive care that is given throughout the journey of the cancer survivor. And I think anybody who has that compassion and the desire to learn and support will be in a position to do it.
So you seem to be saying that it should be then someone who's not directly involved in the treatment of the patient, but rather someone who can focus on prehabilitation and
Yes.
Not be distracted by that. Yeah, and I guess many patients having cancer treatment are going to have different, and they might have surgery, radiotherapy, chemotherapy, immunotherapy, or
Yeah,
whatever.
multiple physicians along the way. Yeah,
multiple physicians, so no one of them can really properly coordinate that as well. So have you struck any barriers or resistance to the whole idea of prehabilitation? And perhaps you can talk about that. As you were saying, joking earlier, some people wondered if you'd spelt it correctly. But what's been the response generally, and what are the barriers to implementation of good prehab for cancer care?
Yeah, I think my biggest hurdle in establishing the clinic was my own colleagues, especially, what can it do? It is not curative. So, it often doesn't strike them that curative care is not the only thing. The patient as a whole has other needs which are more, I know of patients who have stopped chemotherapy because they don't want to lose their hair, who refuse to take chemo because they were losing their hair. I know of patients who refuse to continue treatment for curative diseases at curative stages for simple fears like this. Whether my husband will leave me if I lose my hair, or whether I'll be able to, be sexually active if I'm, things like this. So the psychological support and this physical fitness to enable them to go through the rigors of chemo, I think definitely goes a long way in the treatment outcome, which our oncology specialists fail to understand or fail to support. They feel that their treatment is the curative and nothing else can, like supersede it or help it or facilitate it. So that has been my biggest barrier. And now I start talking about my own experiences and how exercise helped me in preventing some of the complications. And I think people are more willing to listen. And maybe when we show some results in our own center, people will be more receptive to have this concept as a whole and take it forward. That has been one of the biggest challenges. The other challenge is to bring all the multiple disciplinaries into one location at the same time. That has been a challenge for me. We are still working on it. It's very important to have a holistic thing. It's not easy for a patient to run from one room to the other, and to bring everybody together under one roof. And whatever suggestions is given is with the with the consent of all the team members that are involved. That's very important too. So that's something that has been a challenge, and we are working on it. We are progressing very well in giving a team-based advice to the patient. So these are some things that has been challenging. The spaces was a hurdle. We are still working on it. We need a dedicated space in the hospitals. That again, the medical superintendent may or may not support your idea. It's not this clinic is not there in any other hospital in India. Why do you want to have it? These are some of the hurdles that we are still facing, and we are working on it.
Well, I was going to ask you just that the clinic you've set up to do this in Bhopal, how many other clinics are there like it in India or in other parts of the world actually doing this proactively?
I don't know about other parts of the world, but in India, there are 2 centers. They don't have a prehabilitation clinic, but they have what they call as a rehabilitation or a survivorship clinic, where they just do some lifestyle changes. And when they have finished their treatment, when they have finished their follow-up with the consulting physicians for disease recurrence or anything, and then they just come to the lifestyle clinic and then they say, okay, you walk, and things like that. But nobody is addressing any specific long-term effect, or any specific guidance is being given to the survivorship clinic that is being followed in our country. Everybody talks about exercise now. At least the spirometry is being given to all anybody who is waiting for surgery. That's being done very well in every place. But beyond that, nobody is addressing the other aspects of the rehabilitation needs.
Yes. Scott Murray's just made another comment saying, just great prehabilitation for all, by all, including the carers as well. So thank you. And I guess you're facing similar kind of suspicion, I guess, to what palliative care faced right at the beginning from people who were focused purely on curative oncology, and they've fought those battles to establish it as an essential specialty. I was struck, you showed a graph at one point which summarized the interventions against a vertical axis of functional independence and quality of life, and then showed how prehabilitation or no prehabilitation affects both in terms of complications and final disability and so on, which was quite striking. And you made the comment that sometimes the functional independence and quality of life is better after prehab than it was at the time of diagnosis. Now, that's quite intriguing. So can you just unpack that a little bit more for us? How does give us some examples of how functional independence and quality of life actually improves with prehabilitation?
Yeah, there are multiple factors. I think more than just the exercise and the physical fitness, improving the physical fitness and the nutritional status. Also lifestyle changes like stopping, cessation of smoking, alcoholism,
Okay.
and shedding off some of the baggages that we carry along, and looking forward with a fresh perspective of life. I think, as you mentioned, spiritual, emotional well-being, relational well-being. I've even read of people, like making plans and making peace with all the others with whom they were fighting until then. And I think all these things definitely improve the quality of life on multiple levels, not just physical, but on an emotional level, on a spiritual level. And that overall improvement comes out as better quality of life.
Yeah, no, that's wonderful. We're almost out of time, but I just wanted to ask you, finally of all, just a little bit about your own personal testimony, but what in your own journey through cancer, but also helping others on this journey. How has your own Christian faith helped you and sustained you or motivated you to take this work on?
Yeah, when I relate to people, not everyone has the same hope that I had in, uh, life or death, or death was not something that threatened me. And I had the hope of healing in Christ. And that was something that was very strong. That faith was very strong, that helped me through the disease. And I don't see that in some of the people whom I talk with. Even some Christians struggle with that. So I've been able to pray alongside them, help them through the word, and be available for them when they are going through moments of doubt. And with especially with people of other faith, I have been able to share my own that special phrases or words which help me through that, and also get them connected to others who can also speak hope into their lives, or share their faith into their lives, of how healing is not just in our body but in our mind and in our soul.
No, thank you. And in terms of your own personal journey, were there any things that particularly related to your faith that particularly sustained you and helped you to persevere and press on through it?
Yeah, my journey was quite unique in that when the suspicion was there, it was stage 1 disease, and by the time, in 10 days time, I had the surgery. In another 3 days, I had my post-surgical report, and the post-surgical report diagnosis was stage 3, highly advanced perimets. So it was a huge topsy-turvy. Within
Yeah.
10 days, my whole outlook, and it changed to a large extent, and that literally crushed me initially. But then it took some time for me to understand God's plan and all these things, and it helped me to redefine my purpose in life. And that's what has helped me for these last 5 years, and that's what is helping me to push forward, uh, to get into a closer relationship with the Lord, and
Yeah.
closer walk with the Lord, and the strength to support others who go through similar phases in their life. I sure had my questions. I sure had my doubts. I definitely had my but the one thing I never asked was why. Why Lord? Why me? That's something I didn't. I mean, that was something I didn't have to ask the Lord. But there were umpteen number of people, good Christian believers, who helped me through my journey, and I'm very thankful to them for that. And I have been able to do that for the others too.
No, that's brilliant. That's beautiful. Thank you very, very much for sharing that. And we can see already how your own personal experience and the training that you've had has prepared you for this work that you're doing now, passionate to make prehabilitation for cancer much more widely practiced all around the world. And we wish you all the best in that. And we're particularly thankful, Bertha, at ICMDA too, for your involvement as the regional secretary for South Asia, which is probably our most populous region of the 14 in the world. And we know there's so many unreached people groups there and so much work to be done. So thank you so much. So it remains just for me to thank all of you for coming along today and joining us. And we look forward to seeing you again soon on ICMDA webinars. Thank you and God bless you.